It is my pleasure and honor to present the 2025 Diabetes Canada update for the Chronic Kidney Disease and Diabetes Clinical Practice Guideline. Many of these slides are from our presentation at the Diabetes Canada meeting in Halifax in November 2024. Our guideline has now been published in the Canadian Journal of Diabetes in May of 20.
This webinar has been brought to you in partnership with Novo Nordisk.
Once you are familiar with the new practice recommendations from our guideline, if you would like more information in a continuing professional education format to help you change your clinical practice to come in line with the new guideline-directed medical therapy outlined here, please visit these websites. These are my disclosures. Please look at this picture of a recent day in the dialysis unit midway through my morning dialysis shift. What do you notice? Our expectation is that implementation of the recommendations of this chapter with the new pharmacotherapy chapter will dramatically change the natural history of diabetic nephropathy for the better. In Canada, rates of progression to end-stage kidney disease peaked around 2020. This slide in the upper right shows data from all provinces over time, and it comes from the Canadian Organ Renal Replacement Registry. And this is data from 2013 to 2022. And these are new incident patients starting on dialysis. You can see the peak at 2020, and now it's starting to slow down. The impact of the pandemic, or possibly the introduction of SGLT2 inhibitors. I believe it's the introduction of SGLT2 inhibitors. Let's start with the new information on an update on screening recommendations for kidney disease in people with diabetes. Screening for diabetic nephropathy. Our screening recommendations are so important because identifying an individual early on in the development of kidney disease allows you to change the trajectory of their kidney progression. If you find out late that there's heavy proteinuria and a low eGFR, therapy will be helpful in slowing progression, buying that individual extra years before needing dialysis. If you find out early that there is new albuminuria and start therapy, you will buy that individual extra decades before needing dialysis. So, start with the top. Screen all your patients with diabetes every year to look for the new onset of abnormal albuminuria. Also, measure the serum creatinine so that the eGFR can be calculated. Your lab will report on the KFRE, which we will talk about shortly. Knowing these numbers provides an on-ramp for kidney and heart protection. Miss the on-ramp and time is lost. Time is kidney function lost unnecessarily. Next, if the patient has abnormal albuminuria in the A2 range, that's up to 20 milligrams per millimole for the albumin to creatinine ratio, then 2 of 3 tests are needed over at least 3 months to rule out a false positive for diabetic nephropathy. If the proteinuria is already in the A3 range, an ACR of 20 milligrams per millimole or greater, then you can make the diagnosis of diabetic nephropathy right away. Third, if there's a low eGFR below 60 mils per minute, then that patient has chronic kidney disease. If there is abnormal albuminuria in the A2 or A3 range, then that individual has diabetic nephropathy. People with diabetic nephropathy have a chronic kidney disease even if their eGFR is in the normal range. Having an eGFR less than 60 mils per minute with A1 or normal urine albumin levels is less common than diabetic nephropathy and is less well understood. Fortunately, those people were included in the EMPA kidney study and now have an indication for an SGLT2 inhibitor. We will discuss this later. If an individual with diabetes is found to have chronic kidney disease or diabetic nephropathy, then they should have follow-up testing annually. If the eGFR is less than 60 mils per minute and the urine albumin to creatinine ratio is over 20 milligrams per millimole, consider testing more frequently, every 6 months, or every 4 months, or every quarter. When we looked at the data, because people with albumin to creatinine ratios from 2 to 2.9 have much greater risk of progression than people with an albumin to creatinine ratio less than 2, moving the albumin to creatinine ratio up to 3 to harmonize with the rest of the world or in Canada for people without diabetes would mean that we would miss out on time on therapy. The earlier we can alter the trajectory of the decline of kidney function, the better. Moving the albumin to creatinine ratio level higher from 2 to 3 would not make anyone better, and in fact would make people who on screening have ACR levels from 2 to 2.9 worse off. Therefore, we left the albumin to creatinine ratio threshold for normal for people with diabetes in Canada at less than 2 milligrams per millimole. Here's the KDIGO, Kidney Disease Improving Global Outcomes, classification of kidney disease. On the left, you can see the column from G1 to G5. That signifies different levels of kidney function based on the estimated glomerular filtration rate, or GFR. Normal is 60 and above. Stage 3 is broken into A and B, but is an eGFR from 30 to 60 mils per minute. Less than 30 mils per minute, or stage 4, is when nephrologists like myself want to see the patient, and less than 15 is time to consider kidney replacement therapy like dialysis or kidney transplantation. On the top, on the right, are the columns designating the levels of albuminuria. A1 is normal, A2 is what we used to call microalbuminuria, and A3 is what we used to call macroalbuminuria or overt nephropathy. A2 and A3 are abnormal levels of albuminuria, and people with diabetes in that range have diabetic nephropathy. Looking at the heat map, the lower the GFR and the greater the amount of albuminuria, the greater the risk of progressive kidney disease. Also, the greater the risk of cardiovascular disease. These patients need closer and more frequent follow-up in clinic. Let's talk about this new term, the KFRE. It stands for Kidney Failure Risk Equation. Our co-author, Dr. Nav Tangri, almost single-handedly researched and promoted the use of the KFRE so successfully that your lab should include it on your patient results if you have measured the urine albumin to creatinine ratio and the serum creatinine. KFRE is a formula that predicts the risk of kidney failure over time. Nephrologists use the KFRE2, or the risk of end-stage kidney disease in 2 years. The KFRE5 is for primary care. It is the risk of ending up on dialysis in the next 5 years. All you have to remember is that if the KFRE5 is 5 or over, then that person has a risk of needing dialysis in the next 5 years. The significance is that a KFRE of 5 or greater identifies when a referral to your local nephrologist is needed. The components of the KFRE are shown above. Each of these is available to the lab when you order a urine albumin to creatinine ratio and a serum creatinine. Hyperkalemia. For the first time, we have a recommendation about the management of hyperkalemia. In addition to the CKD guideline publication, there is a supplement included that outlines the management of hyperkalemia, including picture sheets that can be given to patients along with dietary advice. We have simplified the classification of hyperkalemia. However, we have made your job a little harder. That is because we want you to continue kidney protection medications that may be raising the potassium if the potassium level is less than 6. We have a table of advice for keeping the potassium under control for those patients, as well as the information in the hyperkalemia management supplement. It is only when the potassium is 6 or higher that the patient's RASI, ACE inhibitors, ARBs, or MRAs should be held, and they should be sent to the emergency for emergency management. That's 6 or higher. So remember, mild or moderate hyperkalemia needs to be managed at the same time that you keep the patient on their RASI and their kidney protective medications. If the patient's in front of you or you're calling them up because the potassium's high, here's a checklist of foods I like to ask the patient about when the lab reports a high potassium level. Bananas, oranges, orange juice, tomatoes, tomato juice, highly refined foods, yogurt, etc. We've created an algorithm to help you through the management of hyperkalemia. Let's start if the potassium is 6 or above. Please stop the ACE inhibitors, the ARBs, the MRAs, that's RASI, and send the patient to the emergency room. After the patient is returned to normal, don't forget to restart the RASI. If the potassium is elevated but less than 6, then look at our supplement table. Consider diet. If there's a metabolic acidosis with low levels of bicarb, then treat it with sodium bicarbonate 500 milligrams twice a day. That helps to remove extra potassium. Consider adding a diuretic for more potassium excretion. SGLT2 inhibitors lower potassium. Even consider a potassium binder like the new Lokelma or Patiromer that are safe and effective, but very pricey if the patient does not have private coverage. This table provides guidance on when to test potassium levels after starting an ACE inhibitor or ARB or MRA. And note the relaxed time frame for the nonsteroidal MRA finerenone, trade name Kerendia, which is 4 weeks, as there is less hyperkalemia with this agent. After an emerge visit, when the patient's RASI has been held, we recommend retesting potassium in a week, and if under control, for example 4.8 or less, to restart the RASI, and have a discussion about limiting dietary potassium, potentially with one of the potassium-related patient handouts from the supplement. Thank you to the dietitians of Sunnybrook for allowing us to use their hyperkalemia picture sheet. When managing patients with diabetic nephropathy, the use of an ACE inhibitor or ARB is foundational for kidney and heart protection. And all the therapies that come after this are built on the maximal tolerated or maximal recommended dose of an ACE inhibitor or an ARB. All the newer therapies in this clinical practice guideline for kidney and heart protection are added to the background of an ACE inhibitor or ARB. SGLT2 inhibitor therapy was initially added to the CKD chapter in 2018 when it was just for patients with CKD and a history of coronary artery disease or many coronary artery disease risk factors. Then in 2020, it was included specifically for patients with diabetes and kidney disease. Here is a recommendation for the use of SGLT2 inhibitors for kidney protection. I have simplified the wording from the actual manuscript to make this recommendation more implementable. For adults with type 2 diabetes and CKD on RASI, if their eGFR is less than 60, they have an indication for an SGLT2 inhibitor, with or without abnormal urine albumin levels. If the eGFR is 60 or more, the indication for SGLT2 inhibitor is for patients with A3 albuminuria. It is quite reasonable to extrapolate this recommendation to start an SGLT2 inhibitor earlier when the ACR is in the A2 range. It is so exciting that we now have 4 therapies for kidney and heart protection for people with diabetes and kidney disease. It is just a short time again that all we had was blood pressure control and RASI. Now we have SGLT2 inhibitors and 2 additional drug classes. Next, I will discuss the 2 new therapies. Subcutaneous semaglutide, trade name Ozempic, was studied in people with type 2 diabetes and A2 or A3 albuminuria in the FLOW study. In this analysis, subcutaneous semaglutide demonstrated a 24% improvement in the composite kidney outcome and also cardiovascular benefit. This is on top of existing RASI therapy and blood pressure control. Here is the recommendation for subcutaneous semaglutide for kidney protection. I've simplified the wording from the actual manuscript to make this recommendation more implementable. For adults with type 2 diabetes and CKD on RASI, if their eGFR is 25 mils per minute or greater and they have abnormal albuminuria, then they have an indication for subcutaneous semaglutide for kidney protection. The nonsteroidal mineralocorticoid receptor antagonist, or NSMRA, finerenone, trade name Kerendia, was studied in people with type 2 diabetes and A2 or A3 albuminuria in the Figaro and Fidelio studies. A pre-planned analysis put the two studies together in a pooled analysis called Fidelity. In this analysis, finerenone demonstrated a 23% improvement in the composite kidney outcome and a 14% improvement in the cardiac outcome. Remember, this is on top of existing RASI therapy and blood pressure control. Here's the recommendation for the use of the NSMRA finerenone for kidney protection. I've simplified the wording from the actual manuscript to make this recommendation more implementable. For adults with type 2 diabetes and CKD on RASI, if their eGFR is 25 mils per minute or greater, and they have abnormal albuminuria, then they have an indication for finerenone if their potassium level is less than 4.8 millimoles per liter. That's for both kidney protection and cardiovascular protection. Now that we have 4 therapies for protecting the kidneys and heart in people with diabetic nephropathy, you may wonder what order is best to use for adding these agents and how many should be added. The first question is easiest. We should try to start with RASI, for example, starting an ACE inhibitor or an ARB. This is on the background of blood pressure control to less than 130 over 80 millimeters of mercury. When it comes to the second class of drug to add, we feel it is best to consider a patient's values and preferences, as you see on the next slide. Thanks to Phil McFarland for the concept of this table. We have listed 5 patient preferences on the left column and how that is reflected in appropriateness or not of adding to RASI with an SGLT2 inhibitor, an NSMRA, or subcutaneous semaglutide. If weight loss is the patient's goal, an SGLT2 inhibitor, possibly with the addition of subcutaneous semaglutide, makes sense. If hyperkalemia has been a problem, then an SGLT2 inhibitor is helpful to reduce the potassium level. If the patient has had previous genital mycotic infections, then they may want to avoid an SGLT2 inhibitor. I should add that it seems that SGLT2 inhibitors, while increasing the risk for yeast infections, do not increase the risk of typical urinary tract infections. So a previous UTI is not a contraindication for an SGLT2 inhibitor. What about adding more than one of the new therapies to an ACE inhibitor or ARB? Presently, there is not sufficient evidence to recommend adding more than one to baseline RASI. A network meta-analysis suggests that they will have added benefit, and to consider adding if the urine albumin to creatinine ratio does not drop down below 2 milligrams per millimole. Again, we do not have sufficient evidence to recommend this. Do I, as a nephrologist, do this in clinic? Yes, I do. But my patients are much further along the pathway to dialysis than in primary care. New evidence is coming in regularly, and we will update you if this advice changes. Finally, I adapted the approach to overall manage diabetic nephropathy from the KDIGO 2023 guideline. On the bottom layer, foundational to our management, is control of food intake, physical activity, smoking cessation, and maintaining a healthy weight. Next, we have 3 levers that we can control. Let's get the blood pressure to target, the LDL cholesterol less than 2 for primary prevention, and maintain blood pressure control, less than 130/80. An ACE inhibitor or ARB will be used for blood pressure control if possible. Now, if there is abnormal albuminuria, we should be adding an SGLT2 inhibitor or GLP-1 receptor agonist, subcutaneous semaglutide, or nonsteroidal MRA, based on a patient's values and preferences. This is a huge step forward to our 2001 recommendation to add RASI to blood pressure control. We are now finally making inroads to preventing progression to end-stage kidney disease. My goal as a nephrologist has always been to put myself out of business in the dialysis unit before I retire. If you follow the recommendations outlined in this chapter, in particular, starting early in the setting of diabetic nephropathy without waiting for the urine albumin-creatinine ratio to be greater than 20 or the GFR falling below 60 mils per minute, your patient should have a good chance of never needing dialysis in their lifetimes as a result of diabetes-induced kidney disease.